Diabetes is a chronic endocrine disorder, so classified because it begins in the pancreas, an endocrine gland that produces insulin. When the pancreas cannot produce enough insulin or the cells of the body do not respond properly to insulin, then you have diabetes. So why are we talking about diabetes as it relates to the cardiovascular system?
One of the most important complications is cardiovascular disease. Diabetes is considered to be a coronary equivalent, and what that means is that a diabetic patient who's never had a heart attack is as likely to have a heart attack as a patient who's already had one. And I'm going to say it again because I know it may sound confusing. A diabetic patient who's never had a heart attack has the same risk of having a heart attack as a patient who's already had one. And so it's very important that we screen for cardiovascular disease. In diabetics, 65% of deaths come from strokes and heart disease. Diabetic patients are 2 to 4 times as likely to have heart attack and stroke than a patient without diabetes. And so it is really, really important that they get screening either by their primary doctors, and they should all probably be seen by a cardiologist.
There is a ray of hope. Diabetes is treatable, and the American Heart Association considers diabetes to be one of the 7 major controllable risk factors for cardiovascular disease. Control your diabetes, and you can reduce your risk for cardiovascular complications.
Once diabetes is diagnosed, then the goal becomes lowering the glucose, achieving glycemic control, and reversing any other complications that can lead to cardiovascular disease. And it is truly a multidisciplinary approach. It takes the endocrinologist working with the primary care physician, the ophthalmologist, a podiatrist, dentist, a nephrologist, and a cardiologist. So patients have to play a role in their healthcare. They have to make sure that they go to all their appointments. And it is possible in this day and age for someone with diabetes to have a really good quality of life because there is appropriate treatment there, but they first have to come to us.
Diabetics want to hit as close to a normal blood glucose level as they can because high levels can damage the cardiac system.
With hyperglycemia, there are changes to the endothelial lining of the blood vessel that make it more prothrombotic, more prone to clots because of inflammation, and there's decreased dilation of the blood vessel. So we believe that by tightening the glycemic control, we can decrease this inflammatory process and prevent the progression to clots and plaque formation and heart disease. We know that in type 1 diabetics, this has held true, meaning the more tight the glycemic control, we're able to reduce the cardiovascular risk. Studies have shown in the type 1 diabetic patient that cardiovascular outcomes are decreased by 57%. And this includes fatal, non-fatal MIs, and stroke. The same hasn't held up, though, in the type 2 diabetics. We do know, we have some studies showing that in type 2 diabetic patients, in the initial period for newly diagnosed diabetics, tight glycemic control can decrease cardiovascular outcomes. But for diabetics who have had long-standing diabetes, it is unclear. However, we still maintain as endocrinologists that tight glycemic control should still be the standard.
Diabetics often have other risk factors for cardiovascular disease, risk factors that are unrelated to the diagnosis of diabetes. So we also have to tackle those risk factors to maintain good cardiovascular health.
Usually they have all these other risk factors, and that includes hypertension. So all diabetics should have a blood pressure that's less than 130/80. And this is not always achieved. We have patients coming to the office who have much higher blood pressures, and we know that this also leads to cardiovascular disease. So one of the goals in a diabetic is to get them to an appropriate blood pressure goal. Also, we target their lipids. All diabetics should have a lipid profile that's within goal, and specifically their LDL should be less than 100, their triglycerides should be under 150, and their HDL should be above 40. If they're not able to achieve this with diet and exercise, as most people aren't able to do, then we add statin therapy to their regimen. The other risk factors that we target are smoking. Smoking cessation has shown to decrease cardiovascular outcomes, and so all diabetic patients are counseled on smoking cessation. Aspirin therapy also has been shown to decrease cardiovascular outcomes, and so all diabetic patients should be on aspirin unless there is some contraindication. And the other risk factor that we target is really the weight, which is one of the biggest issues. As I mentioned before, obesity can cause diabetes, and we need to target that. We try to get our patients to ideal body weight. If we're not able to do that, even losing 5 to 10% of their body weight can have a tremendous impact on their diabetes and on their cardiovascular outcome.
Ultimately, you have to work with your doctor to reduce your risks for cardiovascular disease. Not all diet and exercise programs are appropriate for everyone. You and your doctor have to figure out what is right for you, your lifestyle, and your risk factors. I'm Dr. Mike Rosen, and you're watching the eHealth Network. See you next time.